We gratefully acknowledge that we are uninvited settlers on the traditional, ancestral, unceded, and occupied homelands of the Musqueam, Squamish, Tsleil-Waututh, Coquitlam, and Katzie First Nations, and the Inuit and Métis peoples who call this land home. This video consists of 3 parts. Part 1, clinical considerations and evidence for use. Part 2, requesting Cabotegravir and Rilpivirine. And Part 3, administration of large volume intramuscular injection. Clinical considerations and evidence for the use of Cabotegravir and Rilpivirine extended release injectable suspensions, or Cabenuva. Cabenuva is the brand name of the first long-acting injectable therapy to be approved by Health Canada for the treatment of HIV. It consists of 2 different anti-HIV drugs, Cabotegravir, an integrase inhibitor, and Rilpivirine, a non-nucleoside reverse transcriptase inhibitor. Before starting treatment with Cabenuva injections, there is the option of taking the same 2 drugs by mouth, 1 pill of each drug once a day for a month. This is called an oral lead-in. If there are no side effects or allergic reactions after the oral lead-in, the same drugs can then be given in injectable form. The injectable suspensions are long-acting, and the drugs stay in the body at diminishing levels for about a year after a single injection. The injections can be given either monthly or every 2 months at different doses. Once the patient is ready to start the injections, loading doses of Cabotegravir and Rilpivirine are given as 2 separate intramuscular injections, each 3 milliliters in volume. A month later, the patient receives either doses of 2 mils of each drug once a month, or 3 mils of each drug every 2 months. The intramuscular injections need to be administered by a healthcare professional. Cabenuva has been studied as a treatment for HIV in people who have currently had their viral load suppressed on a standard oral HIV treatment regimen. It is not recommended as a first-line treatment for people living with HIV who are not currently on treatment or do not have undetectable HIV viral load, because there is no evidence from clinical trials to support its use in this situation. In other words, we do not know if it would be safe and/or effective. For patients in these situations, a number of other options, which have been shown to be effective and safe, are available through the BC Centre for Excellence Drug Treatment Program. The clinical trial program for Cabenuva consisted of 5 studies, which about 1,900 adults aged 18 years or older living with HIV were treated with Cabenuva and Rilpivirine injections after their viral load had been suppressed on oral medications. In the latte study, shown in the first row of this slide, Cabenuva and Rilpivirine were given orally to establish the efficacy and safety of this 2-drug regimen in comparison to a standard 3-drug antiretroviral treatment. In studies comparing injectable Cabotegravir and Rilpivirine to standard oral antiretrovirals, shown in the following rows in blue shading on this slide, 821 participants were randomly assigned to receive the injectable treatment, and 647 were randomly assigned to a standard 3-drug oral HIV treatment. The main conclusion from these studies was that in terms of maintaining undetectable viral load, the injectable regimen was non-inferior to standard treatment, meaning that it was as good as, but not better than or worse than, standard antiretroviral treatment. The ALICE-2M study in the gray row at the bottom compared monthly injections to injections every 2 months, and found that the results were similar, making injections every 2 months an equally viable option. However, the injection volumes are larger when given less frequently. In other words, 2 injections of 3 mils if it's given every 2nd month, as compared to 2 injections of 2 mils if given once a month. The BC Centre for Excellence considerations for appropriate use of Cabenuva, as shown on these slides, are evidence-based and guided by the published results of existing research. First of all, unstable antiretroviral therapy and viral load below 40 copies per mil for ideally at least 6 months. To be included in the studies shown on the previous slide, all participants had to have an undetectable viral load on oral HIV treatment for at least 5 months, and in most, or about 75% of cases, it had to be undetectable for at least 6 months. There's limited evidence to suggest that Cabenuva is as effective after a shorter duration of viral load suppression. Contraindications to intramuscular injections. Again, these injections need to be administered by a qualified health professional, and they would not be appropriate for people living with HIV who have needle phobia, bleeding disorders, or have other reasons not to receive intramuscular injections. Willing and able to attend regular clinic appointments for injections. Pharmacokinetic or PK studies and clinical trials indicate that the amount of drug in the blood can fall to subtherapeutic levels if doses are missed, and viral breakthrough can occur, leading to treatment failure and possible resistance to one or both drugs. Such resistance would limit future treatment options in terms of antiretroviral drugs in the same classes, which are major components of modern antiretroviral regimens, specifically integrase inhibitors and non-nucleoside reverse transcriptase inhibitors. If there are absences that are planned in advance, the patient can take oral cabotegravir and rilpivirine daily or another fully suppressive oral antiretroviral regimen to maintain undetectable viral load until they can resume the injections. Not taking any contraindicated medications. This is a requirement because based on pharmacokinetic studies, some drugs may decrease blood levels of cabotegravir and or rilpivirine, which would decrease the drug's effectiveness, again, possibly resulting in treatment failure. For example, this would apply to certain anticonvulsant medications. This treatment is only appropriate for people who have confirmed HIV-1 and not subtype A1 or A6. Cabenuva is not effective against HIV-2, and clinical trials have shown it is less effective against HIV-1 subtypes A1 and A6, which are uncommon in BC. This treatment is not appropriate for people who require a treatment for hepatitis B because neither drug is effective against hepatitis B, unlike some standard oral antiretroviral regimens. Rilpivirine is available as a drug treatment by itself, and anybody who has taken it before and has previous allergy or intolerance to the drug would not be appropriate to receive Cabenuva because, again, the drug remains in the body at detectable levels for about 1 year after injection. It is also not an appropriate treatment for anyone who is pregnant, breastfeeding, or planning pregnancy because there are no safety data in pregnancy, and also 2 drug regimens are not recommended during pregnancy for the treatment of HIV. Since Cabenuva initially came on formulary in BC, the BC Centre for Excellence has adjusted its considerations in May 2023 based on additional information that has since become available. First of all, it was previously an option only in adults aged 18 or more, but some limited data have become available suggesting that it could also be an option in adolescents aged 12 or older and weighing 35 kilograms or more, and this is now available in BC. Previously, the requirements were that resistance to non-nucleoside reverse transcriptase or integrase inhibitors would preclude treatment with Cabenuva. However, this has been revised to specify that if the person has HIV which is resistant to non-nucleosides based on a single resistance mutation at K103N, rilpivirine can still be active, and so this could be a treatment option in that situation. For people with body mass index greater than 30, clinical trial data initially suggested that Cabenuva may be less effective in this setting due to lower drug levels in obese patients, possibly related to injection technique or using needles that were too short. However, new analysis of the study data suggested that high body mass index alone was unlikely to result in treatment failure. However, caution is still advisable in this situation. Cabenuva injections may be safe without a previous oral lead-in with cabotegravir and rilpivirine pills. The oral lead-in, which was previously required, is now optional, based on data from 2 relatively small, non-randomized trials, where side effects were uncommon, and starting injections directly without the oral lead-in was safe in about 400 persons living with HIV, including fewer than 100 women. However, the drugs are known to remain in the body for about a year following an injection, and rare but serious side effects cannot be ruled out with this small sample. In the interest of patient safety, the minimum 28-day oral lead-in is still recommended. In the future, these guidelines will be adjusted if new information becomes available, indicating that Cabenuva is safe and effective for other types of persons living with HIV. In certain situations, prescribers may wish to apply for Cabenuva for persons living with HIV who do not fit this profile. For example, for individuals on oral antiretroviral therapy who have had plasma viral load suppression for less than 6 months. In such circumstances, the provider is requested to justify why this product is preferable to available oral treatment options for that individual. The British Columbia Centre for Excellence reviews all requests on a case-by-case basis.
Antiretroviral medications for the treatment and prevention of HIV infection are available at no cost through the BC CFE's drug treatment program to all medically eligible residents of BC. Any licensed BC physician, as well as nurse practitioners who have completed training for HIV treatment and prevention, may request and prescribe antiretroviral medication through the program. Drug treatment program enrollment information and antiretroviral prescription request forms can be found on the BC CFE website at the link shown at the bottom of the slide. Antiretroviral drug requests are clinically reviewed, and authorized requests are then handled through the centralized HIV pharmacy program. A list of medications available through the BC CFE is posted on the website. For antiretroviral medications denoted with certain restrictions apply, supportive information or documentation should accompany the drug request. Cabotegravir and Rilpivirine long-acting injections are available through the BC CFE drug treatment program. Overall steps in the application process are illustrated. Before applying for the product, there are a number of clinical and logistical considerations for both providers and patients. If these considerations are met, an antiretroviral request form can be submitted to the program with a completed eligibility considerations form for clinical review by the BC CFE. Authorized requests are forwarded to the program pharmacy, who will work with clinicians to coordinate medication shipments according to the client's injection appointments, which are scheduled by the clinic. Guidance documents for Cabotegravir and Rilpivirine can be found on the BC CFE website under Drug Treatment Program Communications. The link to this webpage is shown at the bottom of the slide. These guidance documents include A, eligibility considerations for the prescriber, and B, considerations for the client. Please use them as a guide when considering this treatment. In addition to clinical eligibility, which are listed in the guidance documents shown on the left and are reviewed in the previous section of this presentation, there are also logistical considerations to support this treatment. A secure medication fridge in the clinic that maintains an internal temperature of 2 to 8 degrees Celsius, clinic support for scheduling injection appointments and to remind clients of appointments, also clinic support for the administration of the injections by healthcare provider every month or every 2 months, depending on the regimen, and also that the clinic has a private area to provide gluteal intramuscular injections. The considerations for the client document is shown on the right. Clinicians are asked to review this document with their client to ensure they understand the unique characteristics of the injectable treatment. This includes client willingness and ability to attend in-person clinic treatment appointments every month or every 2 months, understanding that each clinic appointment will last approximately 30 minutes in duration or more, and that injection treatments involve 2 larger volume gluteal intramuscular injections, 1 on each side. Clients should also be aware that pain or discomfort at the injection site may occur. Of note, there is a narrow window for rescheduling injection appointments, which is plus or minus 7 days. Missed or late doses may lead to low drug levels and potentially virologic failure, development of resistance mutations to integrase inhibitors and or non-nucleoside reverse transcriptase inhibitors, and potential loss of future treatment options. Due to the unique requirements for this product, when applying for the medication, clinicians are asked to provide the reason why the client is unable to continue available oral ART options in BC. Oral preparations are available as a lead-in to assess tolerability of the medications prior to initiation of long-acting injections. Oral lead-in is highly recommended but optional and consists of Cabotegravir 30 mg tablet and Rilpivirine 25 mg tablet by mouth once daily for a minimum of 28 days to a maximum of 60 days. Oral medication should be taken together with a meal, which is required for Rilpivirine absorption. Drug-drug interactions differ between oral lead-in versus injections. For example, proton pump inhibitors are contraindicated with oral Rilpivirine, but not with the injectable formulation. After the optional oral lead-in, there are 2 different schedules for the long-acting injections, monthly or every 2 months. The initial IM injection should be administered on the last day of oral therapy. There are 2 injections for a complete dose, and these should be administered at separate gluteal injection sites during the same visit. Initiation dose or doses are followed by maintenance doses. Here is an illustration of the every 2-month dosing schedule option. Similar to the monthly injection schedule, there is a plus or minus 7-day window to reschedule the injection appointment date. Cabenuva supply and delivery is coordinated through the program HIV Pharmacy. You'll be asked to provide contact information for scheduling and receiving refrigerated medication shipments and the healthcare provider administering the injections. Cabotegravir and Rilpivirine injections must be stored in a secure refrigerator in the original carton until ready for use. The product should be brought to room temperature just prior to use. However, due to the short stability at room temperature, the product should not be removed from the refrigerator until the patient has presented to clinic and is ready for the injection. Of note, vials, once removed from the refrigerator, must be used within 6 hours or must be discarded. Vials cannot be cycled in and out of the refrigerator. Also, doses once drawn up in the syringe should be used as soon as possible and must be used within 2 hours, otherwise must also be discarded. Ensure there is adequate time for medication preparation for injection appointments. It's important to manage scheduled and unscheduled missed or late doses. Contingency planning should be implemented for travel plans, transitions in care, treatment failure, and clients lost to follow-up. And this may include injections or potentially oral bridging with a fully suppressive regimen. Management of missed injection doses is dependent on the injection regimen, the stage of the regimen, whether it's initiation or continuation, and the time elapsed since the last dose, as illustrated in the figure. Clinically assess or reassess patients who miss doses to ensure resumption of injections remains clinically appropriate. This may include viral load testing, resistance testing if indicated, and confirmation that the client is able and willing to continue the treatment. Repeating initiation injections may be required in certain circumstances. Some of the side effects reported in subjects in the pooled FLAIR and ATLAS studies and the ATLAS 2M trials are shown in the table. Local injection site reaction was the most frequently reported side effect with the intramuscular injection of Cabotegravir and Rilpivirine. Injection site reactions included pain or discomfort, nodules, and swelling. The majority of injection site reactions were mild to moderate in nature and diminished over time. Other reported side effects included fever, fatigue, and headache, as shown. For complete information on cautions and side effects, as well as administration instructions, please refer to the official product information.
Other things to consider when starting Cabenuva is the kit and how it comes. So there's 2 different kinds of kits. One of the kits, which is kind of orangey colored, is a 3 ml kit, and it has 2 vials, one with 3 ml of Cabotegravir and one with 3 ml of Rilpivirine. The 3 ml kit is the initiation kit, and so everyone starts with that kit. This 3 ml kit is also used for the 2 monthly injection regimen. And the gray or 2 ml kit is then used every month after the initiation doses for the monthly dosing regimen. The 2 ml kit, which also contains Cabotegravir and Rilpivirine, again, 2 syringes and 2 needle tips, both 23 gauge and 1.5 inches long, because we still need to get into that muscle. And so because we are using 3 ml and 2 ml injections, we need a site that can hold that amount of volume. And so Cabenuva has recommended the ventrogluteal site because each of our ventrogluteal sites can hold 5 ml of volume each. And so in order to help our muscle hold that volume, the nurses or healthcare provider will use a special technique called a Z-track injection technique. So for the Z-track injection for the ventrogluteal site, First thing I'm going to do is landmark, and we do that for every injection as it's best practice. So you take the palm of your hand, put it on, feel their hip, through their ball joint, and then between your thumb and your finger, you're going to make a V, and in the center there is where you're going to do the injection. I'm going to clean my site. Now for a Z-track injection, you've got the long, or for any intramuscular injection, you have the long needle tip, so 1.5 inches. I've already landmarked. I'm going to pull the skin about 2 to 3 centimeters from where I'm going to inject. 90-degree angle. Insert the needle tip, inject the medication, pull out the needle, and release the skin. You can apply pressure to the injection site if needed. Make sure to not massage the area. Once the site is okay, you can repeat all the same steps on the other side. Make sure that you use your safety needles and dispose of your needles and vials in the proper containers. Clients would then stay in the clinic for 10 minutes after each injection for observation.
In summary, Cabotegravir and Rilpivirine long-acting injections are available through the BC CFE drug treatment program. As with all antiretroviral medication in BC, distribution of Cabotegravir Rilpivirine is coordinated through the HIV program central pharmacy, St. Paul's Hospital Ambulatory Pharmacy. Secure, refrigerated clinic storage and proper handling are required to maintain integrity of the product. It is important to select appropriate candidates and to manage planned or unplanned missed doses in order to prevent subtherapeutic drug levels, viral breakthrough, and possible development of resistance to integrase inhibitors and/or non-nucleoside reverse transcriptase inhibitors, which would limit future HIV treatment options. Injections are given either every 1 month or every 2 months. Each dose consists of 2 gluteal intramuscular injections in the buttocks via the Z-track method, administered by a qualified healthcare provider. Injection site reactions can occur and may require management. Typically, they do diminish with ongoing treatment. Please refer to the BCCFE website for evidence-based guidance, practical considerations, and the prescription request form.